Let's begin. I'm Sarah Goodyear. I'm a journalist and I'm co-host of the podcast, The War on Cars. And let me welcome you to the first virtual only VitalTalks of 2020. In just a few minutes, I'll be joined by our esteemed panel for a conversation on an incredibly timely and important topic. The world wasn't prepared for a pandemic, but it could be. And I'm doing this, as I said, from Brooklyn, New York. From the place where I'm sitting right now, back in March and April, I could hear sirens going all day and all night as people were taken to the hospital at the height of the crisis here in New York. And so it's a very personal question to me, how we could prepare better for a pandemic like this, and how we could avoid the loss of life and economic catastrophe that emanated from that. We've got a lot to cover today. I want to start with a few housekeeping items. At the bottom of the screen, you'll see the chat function, and also there is a Q&A function. You can use the chat to speak among yourselves or to send a message to the Vital Strategies team, but that's not where we're going to be doing questions for the panelists. If you would ask questions for the speakers, you do that in the Q&A box. Please share any question you'd like there, and you can also ask questions on Twitter using the hashtag VitalTalks. Hashtag VitalTalks, one word. You can send in your questions at any time during the talk, and we really want this to be a dynamic discussion and an open discussion, so please contribute there. It is my honor to introduce our first speaker who will be kicking off the event today, Dr. Tom Frieden. Dr. Frieden is the former director of the U.S. Centers for Disease Control and Prevention and the former commissioner of the New York City Health Department. He is currently the president and CEO of Resolve to Save Lives, which is an initiative of Vital Strategies and a leading voice in the COVID-19 response. With that, I hand it over to you, Dr. Frieden.
Thanks so much. Welcome, everybody. Thanks, and I'd like to acknowledge the many people at Vital Strategies and within Vital Strategies, Resolve to Save Lives, who made this possible. This is the first time we're doing a virtual Vital Talk. It's a new world. A lot has changed, but a lot is the same. One thing that's the same is that we're not prepared as we should be for the next pandemic. Today, we're focusing on how the world was not ready for a pandemic, but it could and should be. We're now 8 months into the pandemic from the date that WHO notified it to the world and CDC was made aware. It's less than 7 months since the first US death, and now there have been more than 180,000 reported deaths and well over 200,000 excess deaths in the United States. The virus is still out of control in much of this country, especially parts of the Midwest and South. The Northeast of the US is the only region doing relatively well, but we're not crushing the curve. We're still seeing a steady plateau of cases, and that's not what we'd like to see, because that means the risk of explosion is ever present. Sadly, we've not seen leadership or comprehensive action in the US. Masks are still not required and even actively discouraged in some places. There have been recent changes in CDC guidelines which are unprecedented and indefensible. They represent political meddling with the response to the virus. And we know that this virus does not respond to political spin. It responds to science-based efforts. Testing is still not nearly as available or as rapid as it needs to be. Schools are opening in communities that are not ready. And inevitably, we will see large outbreaks everywhere from daycares to colleges. Without leadership from governments, we face a real challenge. As a small, non-governmental organization, we do what we can. And right now, one of the things that is most powerful is individual level action and community level action. Masks reduce the spread of COVID. They save lives. They're one of the least expensive and most effective ways of stopping disease. There have been too many casualties from this disease. Too many people have died tragically. And like the moderator, I also listened all through March and April to the sound of sirens. I think that's what all of us will remember for the rest of our lives. Day in and day out, sirens representing tragedies that will continue to reverberate for months and years. It's not too late for us to get back on track, to save lives and to restore our economy. Last week, we released guidance on how to promote mask use and how to track it. This is one example of a community-led intervention that can make a huge difference. There are best practices on when, where, and what type of mask to use, guidance for policymakers and communities on mandates, communication and community engagement strategies to encourage use. Every community has strengths, and the challenge in epidemic prevention and control is to enlist those strengths in responding to the emergency and preventing the next one. Resolve has been running full steam ahead since the start of the pandemic. We've implemented initiatives in the United States and around the world. We're tracking the US response with a partner organization, covidexitstrategy.org. And we issue, through the great work of Sarah Shapar and his staff, weekly scientific reviews summarizing new and emerging evidence. They're virtually an encyclopedia of COVID. I recommend them to you on our website, preventepidemics.org. We've released a series of technical documents on an adaptive response, the box it in strategy, a risk-based alert level system, global and contact tracing playbooks, policies on masks, schools, essential indicators, healthcare safety, how to measure and reduce excess mortality, and much more. We've published dozens of peer-reviewed articles, close to 100 op-eds, 1,000 media appearances, and we'll keep on working on COVID until it's no longer a public health threat. And all of this while maintaining our cardiovascular prevention work as well as we can. I want to thank the moderator, Sarah Goodyear, Resolve's prevention specialists, Amanda McClelland and Chris Lee, Dr. Emmanuel Agogo, Resolve's Nigeria country representatives, Dr. Immaculate Nabukenya, Senior Project Manager for Global Health Security at Uganda's Infectious Disease Institute. They'll share experiences and lessons learned from the response to COVID and detail what we have to focus on going forward to prepare the world so much better for the next pandemic, because it is inevitable that there will be future public health disasters. What's not inevitable is that we will continue to be so woefully underprepared. Thank you very much, and I'm looking forward to participating and listening to the great Vital Talk.
Thank you so much, Dr. Frieden. I'm now going to introduce our panel of experts. Amanda McClelland is a notable expert in international public health management, especially in emergency health, epidemic control, mass casualty and low resource settings, disease prevention and response operations. Her achievements include coordinating frontline Ebola response during the 2014 Ebola epidemic, for which she received the 2015 Florence Nightingale Medal for exceptional courage and for publishing a landmark study on the impact of unsafe burial practices, which confirmed the life-saving benefits of a comprehensive approach to Ebola prevention. She brings this expertise to prevent epidemics as Senior Vice President at Resolve to Save Lives at Vital Strategies. Dr. Christopher Lee is Senior Technical Advisor for Prevent Epidemics at Resolve to Save Lives. In this capacity, he works closely with the WHO Health Emergencies Program and provides direct technical assistance for epidemic preparedness in countries, primarily in Nigeria, where he was seconded as Health Security Advisor to the Nigeria Center for Disease Control, NCDC. Christopher oversees healthcare worker training programs for Resolve to Save Lives, to strengthen facility and national infection prevention and control activities for COVID-19. To date, 20,000 healthcare workers in 20 African countries have been trained. He also provides strategic support for countries and partner organizations on the use of data modeling and policy guidance for the COVID-19 response. Dr. Emmanuel Agogo is a global health security and international health system strengthening expert with an interest in laboratory systems. He was a founding staff member of the Nigeria Center for Disease Control, and prior to that, co-led the largest rollout of gene expert machines ever funded by the Global Fund for AIDS, TB, Malaria. Emmanuel was a 2019 Biosecurity Fellow at the Johns Hopkins Center for Health Security and has wide experience supporting the joint external evaluation of the international health regulations in several African countries. He is country representative for Resolve to Save Lives in Nigeria, where he provides and coordinates technical assistance to the NCDC and the Nigeria COVID-19 response. Dr. Nabukenya Immaculate is a public health practitioner with more than 13 years experience in managing epidemiological data, investigating and responding to disease outbreaks in Uganda, Sierra Leone, and Kenya. She has responded to Ebola, yellow fever, anthrax, cholera, hepatitis E, typhoid, Rift Valley fever, meningococcal meningitis, and others. As an epidemiologist, she has mentored and trained more than 100 field and clinical epidemiologists and supervised and led research teams investigating several disease causations, including, most recently, COVID-19. She inspires young professionals to join the public health field to improve health outcomes. As a scientist, Immaculate has authored more than 20 scientific articles and 2 book chapters. She is the Senior Project Manager, Global Health Security Program at the Infectious Diseases Institute. Wow, what an amazing lineup and what deep and broad expertise in this field. So let's get started hearing from you people. I'm going to give the first question to Amanda, and I'd like to know, how did you get started in epidemic preparedness, and why is it so important for countries to invest in preparedness?
Thanks so much, Sarah. I think how I got started in epidemic preparedness was really a recognition after a decade of responding to epidemics that I was going back to the same countries to support the same teams to meet the same challenges. And despite the best efforts of those country teams, they're unable to really invest in preparedness because of lack of political will, lack of financial support, and also dedicated human resources. And we were going from one epidemic to another. And so really it was seeing that cycle of panic and neglect that really challenged me, I think, to take a step back from the emergency response and really start to focus on how we could better prepare, not just health systems, but communities. And this recognition that this wasn't a health problem, but as much a political and leadership issue, as well as a lack of community engagement. And so really starting to think about epidemics as a multi-dimensional problem that needed a multi-dimensional response.
Thank you so much. I'm gonna throw a follow-up to Chris. How prepared were countries before COVID-19? I mean, you know, it's not like this is news that this kind of thing could happen. Obviously, you people in the field were aware of that. But what was the level of preparedness in different countries?
Thanks, Sarah. You know, even before the devastating pandemic of COVID, we knew we weren't ready. Ever since the West Africa Ebola epidemic in 2014 and 2015, countries began to perform a rigorous assessment of their abilities to find, stop, and prevent epidemics. And this was called the Joint External Evaluation and led by WHO, or the World Health Organization. And sadly, of the 194 member states in WHO, only 15 of them were better prepared. And the majority of countries were either not prepared or had substantial work to do. And what's most alarming is that more than 50% of the world's population actually lives in a country that never did this report card, never did this assessment. So those systems' capacities for how to find something like COVID and respond to it effectively were really unknown. The reason why this is important is because the JEE isn't just a report card, but it's also a framework and a roadmap for building capacities at the country level. Because as COVID illustrates, even if your own country is prepared, the lack of preparedness in any country in the world can really lead to the spread of an infectious agent. And this really highlights the need to work together. The joint external evaluation also serves another important role to provide normative standards for financing and investments in health security and preparedness. We illustrate these results on our website at preventepidemics.org, but we've also used these results to take a guess at how much it would cost the world to have been prepared for a large epidemic event. Maybe not a pandemic like COVID, but an investment of about $1 per person per year could make the world a safer place. And the level of investment in preparedness just has not approached that. Meanwhile, the United Nations Department of Economic and Social Affairs has estimated COVID will cause an $8.5 trillion loss in global economic output. And the Asia Development Bank put out a similar estimate at $8.8 trillion. All of that said, it's clear that more countries need to take this assessment and capacity building seriously, and more donors, including development banks, and most importantly, countries themselves need to put a dollar down to improve this problem. I'll just end with saying that the JEE wasn't a perfect report card. We know there are some countries, including the US, that scored very well on this report card and in real life scenarios have not performed as well as you would expect. And I would just say that's because the JEE is measuring technical capacities, but not necessarily the demonstrated capabilities. So influences like leadership or governance and data sharing aren't traditionally measured by the JEE. And there are some really critical technical areas that could be featured more prominently to measure preparedness, including making sure that your health systems have the capacity to treat a large number of patients, having oxygen, and being able to protect your workforce. But these are actually technical problems that are relatively easy to fix. We just need to come together, work on the solution, and invest in that. The other half of that is we need to start using our experiences from real world events like COVID, but also the everyday outbreaks that never became epidemics or pandemics to understand how to improve the systems. And we've seen that countries that experienced SARS in 2003 have actually done very, very well in responding to COVID. So we should look at real world events, understand the bottlenecks and challenges that they pose, and improve our systems to improve our current response and save lives now, and invest in global preparedness to save lives later.
Immaculate, I know that Uganda has a dedicated team to support preparedness. How did the existence of that team help the nation respond to the emergence of COVID?
Thank you so much, Sarah, for that, and Christopher, for having given us the background to JEE and how the countries fared. Uganda is one of the few countries that completed the joint external evaluation in Africa. And after that, in 2018, we developed the National Action Plan for Health Security, which is a 5-year plan. And we critically looked at our areas of weakness, but we looked also at across the board, all the 19 technical areas. Where are we weak and where do we need to put further efforts? Following that, we actually launched that plan last year in August. So 1 year down the road, we actually find ourselves in the mess that we anticipated, but we could kind of get very mixed feelings about at the beginning, when we would say there can be a pandemic of this magnitude, or we need, for example, the link between public health and security. People would not understand how the health workers would need to interact, for example, with the enforcers of the law. So we had 3 areas that were very weak at the start of the JEE process. and that was financing or having an organized modality for dispensing modalities to respond to any outbreak. We had points of entry that were porous and were not responding. We didn't have the capability to check who was in and who's out, or any effort to reduce any transmission of infectious diseases of potential international concern. But also preparedness was another weak area. So we worked on these three. Yes, last year, the dedicated team of 6 was focused on this. And we made such a mileage, and we launched this effort, and we got a lot of buy-in from all the sectors government. So we got funding from Resolve to Save Lives that kickstarted most of the processes and activities, but also we tasked the National Development Plan to put resources, for the government to put resources and donors to put resources in health security. So we did so well that when this came up, I think we're not starting from scratch. We're not just imagining what could be. We started from the very systems that we had developed. For example, our public health law had expired, was made in 1939. And when you look at it, it's no longer moving with the tandem of expected outbreaks like COVID-19. So the legal reform process had already commenced. And once this started, the legal advisor who is part of the team has been very instrumental in developing the roles as we move along. When the government needs to make a change or to put up a public health measure, it needs to use the law, which law was not speaking to the current events. So using that, we've made, we've over 10 rules that have addressed different actions as we moved along with the outbreak. To date, we have just a bit over 3,000 cases. We seem to be having a bit more cases per day. We seem to be approaching the peak of the outbreak. However, still the same team makes sure that we are supporting. For example, in terms of financing, we already mobilized as a team over $1 million, but also we had put up a discussion, and through a consultant last year, we had tasked government to think through the contingency fund, which is supposed to put about 5% of the national budget to support response to an outbreak of such a magnitude. So because these processes were all done, once this happened, the government had a mechanism of disbursing resources timely from the National Treasury, had resources from the Ministry of Health, and all the other partners just joined in and made sure financing was timely. But also we used the same platform to interest the public. So the public, businesses, all donated different resources. Some donated water, others food, beddings, money. And so this was used to support the very coffers from government and other donations from outside. When it comes to preparedness, we had different plans. We had simulated several scenarios, and some of them have exactly played out as we had. We had the National Preparedness Plan that is multi-hazard, that has several hazards. And at the time of COVID, we had floods, very large-scale floods that wiped out a whole hospital in the western part of the country. We had the other infectious diseases like yellow fever. We were ready to vaccinate, and we could not because of COVID-19 outbreak and the catapult it had on everything. When it comes to the involvement in convening meetings, we were already a trusted group that when we say, please, let's meet or let's use this forum, we already were using Zoom, for example, for our meetings. So adapting to the new response mode or to even the method of operations was much quicker. So all in all, it helps to be prepared. It helps to work through the community. It helps to have a dedicated team that you can count on. It helps to assess your weaknesses, and much as it's not capacity, the capability can be enhanced once you actually have a challenge. So I think Uganda has been better prepared than other countries that didn't go through this exercise.
Is some of that preparedness, Immaculate, from past experience with Ebola, and did that help to to facilitate political and social engagement on this current pandemic?
Exactly. So Uganda has gone through, I think the last outbreak we had was last year, the 7th outbreak of Ebola. The number of cases have dwindled. The first outbreak in Gulu in 2000 had 400 cases plus. The latest doesn't go beyond 3 cases. The last one we had in Kasese was 3 cases of Ebola. We had the capability of screening at points of entry. We were able to detect it timely and manage it. But also other outbreaks like anthrax that call for multi-sectoral approach, where you deal with Ministry of Agriculture, where we deal with Ministry of Water and Environment, with tourism, all coming together to work together. So the One Health approach, for example, in Uganda is really strong. And this is not something about one ministry. You realize that COVID-19 is about everyone, the community, the security, every player has a role to give. And so we were much more prepared. When it comes to issues around community mobilization, Ebola, talk of Rift Valley fever, they all call for the same approach, where the risk communication needs to be strong, but the community needs to trust the very messages and approaches used to deliver those messages. So you're right, coming from that experience and having a big team of people who are knowledgeable in this. I know that so many Ugandans are across the world leading efforts in responding to COVID-19, but even previously with other big outbreaks like Ebola. For example, in 2014 to 2016, we had over 60 Ugandans that were in West Africa, different parts of West Africa, leading and supporting. Recently in DRC, we're still part of that big team that was supporting DRC to manage the Ebola outbreak. So I think coming from that experience helps a lot.
Yes, and Emmanuel, maybe you could speak about Nigeria's experience and how Nigeria has had to respond to yellow fever outbreaks, monkeypox, and how has that informed that nation's response to COVID?
Hello, Sarah. Thanks for the question, and thanks, colleagues, for making my work so easy. I think you've set the stage to really talk about how countries have been preparing over the last few years, and for the last 3 years to be specific, and obviously from the time of the Ebola outbreak in Nigeria, the country has leveraged a lot of experiences in the past, and that has come to bear even in what is happening at the moment. For instance, investment in human resources was very critical. So ensuring that, the NFLTIP was developed. So they have the National Nigerian Field Epidemiology Training Program. That was a program that has trained field epidemiologists across the country. We've had investments through other mechanisms such as the Global Fund, where they've supported lab systems for HIV and malaria. There's been investments also in the area of polio, huge investments from partners, building an infrastructure around, community surveillance, building infrastructure around, HR systems at the community level, a lot of community engagement and understanding how communities function. These systems have also helped build, cold chain, supply chain systems in partnership with UNICEF and many of the other partners. The PEPFAR program has been very instrumental also in building systems. So building systems around, especially laboratory, where systems that were put in place to help with diagnosing HIV, especially the molecular diagnosis for HIV, as well as molecular systems in place for doing early infant diagnosis, as well as doing viral load testing. All these systems that have been put in place over the years have helped in making the country better prepared. And these came to bear in the joint external evaluation that was conducted in the country in 2017. And Nigeria pushed ahead in 2019 with support of Resolve and leadership by WHO, and of course involvement of leadership by NCDC to do a review of the joint external evaluation. And this process that was done actually, you may know that the system or the mechanism for doing that assessment changed, and it became a bit more stringent. But even between a 2-year period doing a JEE from 2017 to 2019, the country actually improved in about 7 thematic areas. And the JEE assessment, which Chris mentioned, really asks questions around how well are you responding to outbreaks? How well are you detecting? What lab systems you have in place? And these assessments show that between the time the initial assessment was done, the country began to, in responding to the various outbreaks that happened in that intervening period, which you mentioned, some of them which you mentioned, monkeypox, for instance, meningitis happened in the up north, monkeypox happened in down south. We had Lassa fever, which year on year with improving surveillance systems, we've been having increased numbers, but we had the largest at the time outbreak in 2018. And that meant that we had to improve surveillance systems, we had to improve diagnostic systems, we had to also improve the human resources, not only at the national level. And increasingly, what has happened in terms of building was that we built a lot of capacity at the national level. Just before COVID-19 struck, there was an understanding that you can build so much capacity at the national level, but you need to start looking at what's happening at the subnational level. And so a lot of the work that Resolve actually supported NCDC and were there at the time to develop state level strategies. So beginning to look at what are the best buys that you need to invest in at the subnational level to make sure that even at the state level, you're better prepared. And it has come to bear even as those processes were unfolding, and that at the subnational level, lab systems are important, HR systems are important, and the regulatory and governance systems are important. Using electronic surveillance systems like SOMAS, which has been developed, which is developed with support from the government, but it's also been rolled out widely across West Africa. Such systems are important. And these subnational interventions have become quite clear. Final thing is that there's been a system of trying to learn from the experiences. So after action reviews have been held after all these major outbreaks. And these after action reviews are like a sit back to look at what has happened, what went well, what didn't go so well, how do we learn, how do we improve? And those after action reviews have been done for virtually all the outbreaks that have happened. And those lessons have been part of what has helped the system to improve. Even in the course of COVID-19, NCDC, we support Resolve, and some partners supported NCDC to do a midterm review. So at about the 90-day mark, we did an after-action review and looked at, with the COVID response so far, how well are we doing? Where are the bottlenecks? And I think that has helped with refocusing and coming up with a new plan, which NCDC is implementing. That was also replicated at the national level, at the PTF level.
Right.
So, I'm sure that there may be some questions to talk about this.
Yeah, before we get to the audience questions, I'd just like to quickly ask each of you in a few words to talk about what specific to COVID-19 going forward, what the priorities are that you're seeing. And let's go back to Amanda to start this and just quickly, specific to COVID-19, what are the priorities going forward?
I think the priorities for more globally are getting the global architecture right and to move away from this looking for the one solution. This is not about masks or just about vaccines. This is about how the public health interventions work together with, importantly, political leadership, not just domestically, but globally. We're not going to stop COVID unless we work together. To Chris's point, that you're only as prepared as the country next door or the country one plane ride away. And so, I really think we're learning every day. We have to be evidence-driven with good political backing and leadership to use the science effectively and combining interventions rather than looking for that one silver bullet or that one vaccine.
Chris? Or Immaculate, if you want to jump in.
Yes. There is need for financing and for funding. Countries are struggling, but what is in your country is what is next door. So it's important to look at what you can equitably resource from within, how you can respond without necessarily looking for resources elsewhere, but starting with what you have. 2, we need to work with the communities and make sure that we build trust. if the community believes the message you give, if the community trusts what the public health leaders are saying, if the political leaders are saying the same as the public health leaders, then we can use minimum interventions to achieve big impact before we get a vaccine and before we get a cure.
Chris, do you have any thoughts?
Sure. Yeah. So before COVID, I used to work at sort of the global and national levels, and working on the COVID response, I've really realized the importance of protecting our healthcare workers at every level. In every health facility, our healthcare workforce is bearing a huge brunt of the responsibility and the burden of deaths in COVID, and that's unacceptable. And the healthcare workforce is extremely fragile, particularly in the African countries in which we work. And a lost healthcare worker means a number of secondary losses because of people's failure to be able to access vaccination services or safe maternal child health or HIV and TB care. And then I would just like to reinforce the point that Immaculate made, that working at the primary health facility level means that you have to work with communities, build the trust between communities and their healthcare workers and their healthcare systems to combat misinformation and make sure that people know how and where to get care.
And Emmanuel, do you have thoughts about what the priorities are immediately, just in terms of this pandemic?
Well, I think one of the key priorities, to add to what everyone has said, is really the issue of data and evidence. So the Resolve to Save Lives have really worked during this time to develop, data packages that have been very useful. And if you check the epidemics.org website, there's a Africa Data Insights. Recently, some data has been looked at in terms of, how well have countries responded to the how well have countries implemented non-pharmaceutical interventions. I think that's been a critical piece of work. You can check it. It's also part of work that Resolve has done, has been the Partnership for Evidence-Based Response to COVID-19. So really looking at what is the evidence, when we say masks, when we say distancing, what's the evidence, and how do we provide this information to the decision makers to ensure that they are not making decisions just based on whims and interests. Another thing that's really is around building local data analysis capacity. I think that going forward, countries need to have the capacity themselves, and not only at the national level, also at the state and subnational levels, so that they can look at their data and make sense of it and design programs and implement in a way that is relevant to them. And that's where, linking to what Immaculate said earlier, the community convincing, and you can have buy-in from people. Over.
Okay, so we're going to go to some of the questions. We're getting all these amazing questions from people around the world. One of them is from here in New York, from where I am. Mayor de Blasio said this morning, the New York mayor said he's going to require monthly testing of teachers and students. And this seems contrary to the box-it-in approach, which Resolve to Save Lives has promoted. Can you share practical examples of how to safely open schools? And is that true that this is contrary to that approach? Chris, can you speak to that?
Sure, thanks, Sarah. So maybe some of the participants or listeners might not be familiar with the box-it-in strategy. So this is a strategy from Resolve to Save Lives that really, to suppress or to end this pandemic, we need to be able to identify cases rapidly, isolate cases, identify their contacts, and ensure those contacts quarantine. And this involves sophisticated laboratory and surveillance capacities. I don't think that a screening strategy at schools, for instance, is contrary to this approach, because the box-it-in strategy is saying, when you have cases, these are the things you can do in order to contain the spread of the pandemic among the cases that you know about. And what Mayor de Blasio, and I'm not familiar with his statement, so I can't verify if he said it or not, but what he's describing is really another approach, which is complementary, which is a screening approach. And I think that as testing capacity increases and there's a desire to be able to open societies and resume normal activities, there will be some level of screening among people who might not have symptoms to make sure that they can interact safely with one another. I think right now the jury is still out on the precise frequency of that kind of testing and how it should be implemented. But I don't think it's at all contrary to the overall goal of quickly identifying cases. Screening lets you actually identify asymptomatic cases and making sure that those people aren't going on to infect others. I think that safely reopening schools is a very large can of worms, but there are several guidance documents out there. In general, I think what's really important is having systems to ensure that both teachers and students are screened regularly for symptoms before they congregate, that the 3 W's are followed. That's wearing a mask, washing your hands, and watching your distance, keeping sufficient physical distance in place. And that if there are infections detected in schools, obviously you need engineering and administrative controls in these schools to prevent these infections, that there are contingency plans for home-based learning or outdoor learning that can continue as to not disrupt educations.
Great. We have another question from Sarah Matthews about talking about the U.S. had technical expertise and preparedness plans, but the failure was at community engagement and building trust, as well as leadership. And Dr. McClelland was talking about this, and how could we have better prepared for building those specific capabilities, community engagement, building trust, leadership?
I think trust has been the fundamental piece that's shown success in countries and communities that have engaged and trusted their leadership with clear, consistent communication, whether that's about the scientific unknowns or the plans going forward, have done much better than countries that are divided or lack that trust. And so it goes to the point that Immaculate made around having the public health and the political leadership speaking with one voice. This is going to be critical as we go forward, especially as vaccines start to come into play. It's not just for COVID, but it's every public health intervention, and especially in high-risk outbreaks, we see trust as the fundamental piece that you can't build once the outbreak starts. And so it's a strange concept, but building that trust as part of preparedness is critical, because it's the one thing that you can't surge. We can surge medical countermeasures, we can surge additional finances and support, but you can't build that trust once the epidemic starts. And so it's critical that clear, consistent communication, good health literacy, and a trust in science is something that we continually invest in.
And the next question, which I think is going to have to be the last one, is asking something that's, I think, a little bit related. Have you involved, any of you, social and behavioral science and scientists in your response, given so much of what is needed requires actions by the population to prevent the spread?
So perhaps I can answer and then pass on to my country colleagues. I think this has been critical for us as a lesson over many years. As a nurse and the interface between communities and medical interventions, it's been critical in multiple outbreaks that I've been involved in. But we've collaborated with Africa CDC and the WHO to form a partnership called PERC. This is specifically the Partnership for Evidence Response to COVID, to build in that social science information, but to put it in the context of epidemiology, economic and social indicators. And so actually next week, we'll release the second wave of data from PERC, which is really about trying to put, not having the social science data off to the side as a nice to have, but really burying it inside the epidemiological data as a key driver, not only of transmission, but of control. But maybe I can pass to my country colleagues to comment further.
I could come in quickly. Thanks, Amanda, for that. I'm currently in a meeting where we are analyzing the data from a feedback loop. We've done research. We decided that we've passed enough messages, but we are starting to see lower levels of compliance with the message. So we wanted to find out, is the message out there? What is the level of knowledge? And we've done it across the country. So right now we are putting it together. And what we are seeing is that this is going to guide the next messaging. People are telling us why they don't trust some segments of the message or some parts of the response, who they want to talk to them. For example, they challenged us, the president is good, but he's not a scientist. Can we listen more to the scientists? Why do we have to listen to the president? Yet he's okay, we trust him, but not for this. If it's another war, yes, but this is a war for science. So once we use that information to guide the intervention, I think you talk to an audience that is ready to listen, because for now, they have the information, they've had it all, they are tired of it. So it needs that change from us. And it only comes from social sciences research to guide your appropriate messaging.
Okay, well, thank you so much to our panelists. This really has been.
And if I may just add a few
Oh,
words
yes.
to that.
Yes, please, go right ahead.
One of the things that has been clear.
Okay, I was having a little
so
trouble.
I was just saying that, one of the things that has been critical in the COVID response is the fact that the introduction of non-pharmaceutical interventions caused some significant social impact on families. And a study that was done actually in Nigeria just before, okay. Oh. Sorry, okay. So it showed that a lot of people were not able to, did not have reserves at home before the introduction of NPHIs. And that has an impact in whether they follow the recommendations, the public health.
Okay, it seems like we've lost Emmanuel there. That's not just me, right? Everybody. Okay, so so this has been such an incredible conversation. Obviously, we could go on for a lot longer, and I'm sorry to have to kind of bring it around, but I do have to do that. I just want to acknowledge our audience, which is just this incredible array of public health professionals. There are media people here, there are public health students, there are policymakers, and we're all living and working in this global pandemic. We're all experiencing this and learning as we go along. And as we cope with this new normal, I think everybody around the world wants to know, what can I do? How can I help? What is the right way to act in this new place? Where do we start? How do we begin? And so if each of you could just in a lightning round quickly give us a point that we could hold on to going forward, a takeaway, and I'm going to start with Immaculate.
I think we've done a lot, but Uganda is trying to build as much community trust as possible. Is trying to focus on the communities, uptaking the reporting of cases and working with government to report any suspected cases, accept to be isolated and quarantined, and believe in this as the best response to this outbreak. So the community is becoming the hinge for Uganda's response. Yep.
Great. Emmanuel, you're back with us. What would be your 1 minute takeaway?
Well, I think that we've looked at the data, importance of data, and looking at the lens of lives, livelihood, and the long term in responding at the national level. I think that would be my takeaway. So lives, livelihood, long term response, and then,
Chris, what about you?
Listen, from the big picture, there's not just going to be one magic bullet. Until a vaccine or treatment is available to everyone, we need national leadership that places science above politics. We need to use data from multiple sources, including the epidemiologic, but also the behavioral and economic data to inform decision-making. We need to strengthen communications and give tools to citizens to protect themselves and their families, and invest in preparedness and health systems to protect healthcare workers and communities. But this is all very abstract, and I just want to sort of emphasize that every single person participating in this webinar can do something to protect themselves and the lives of the people around them by embracing these 3 W's: wearing a mask, washing your hands, and watching your distance. Tell your friends, because this seems like a small act, but each person who does it really removes themselves from the pool of susceptible individuals, and this action can be one of the many different arrows we have in our pocket that everybody has to contain the spread of COVID.
That's very inspiring, Chris. Thank you. It does feel good to think that what we do personally can make a difference. Amanda.
Yeah, I would just like to echo that. I think beyond what we can do to slow COVID as individuals is to recognize that preparedness is everybody's business, that this is not just something that we should be focused on for COVID. There's other secondary impacts beyond COVID with the breakdown of health systems. And so, you know, my takeaway is that the preparedness is really something that everyone can do for themselves personally, for their communities, and as part of really demanding change at the government and political level.
Thank you. That's really great to hear. Okay, well, with that, I'm going to start wrapping it up. Thank you to all of the speakers, because your on the ground experience and your depth of understanding of these questions is actually quite reassuring, I think, at a time that's just filled with anxiety. So thank you for your calm expertise. It's really, really welcome. And for your dedication to protecting others and protecting public health. It's very inspiring to me. You can learn more to our wonderful audience. I also want to thank you for, I'm sorry that we couldn't get to way more of the questions, because they're great questions and we have so many great questions, and obviously, you know, this could go on, but we do have to wrap it up. But you can learn more by going to preventepidemics.org, and you can follow along on the social media for Vital Strategies. And I hope that you could join us for our next Vital Talks, which is coming up on September 17th and deals with another crucial issue, which is food policy. And you can register for that now at vitalstrategies.org. And again, at vitalstrategies.org, you can find all the links you want for all sorts of data, social connections, and please do that. I am Sarah Goodyear. I want to thank you very much for joining us, and I hope to see you next time. Take care.
Bye.